Here we will listen to someone who has really championed this field. It's a great pleasure to welcome Professor Dr. Johannes Kaesmacher from Bern University Hospital in Switzerland. Please.
Thank you for this kind introduction. So this is going to be another session on cone beam CT. Especially its value in contemporary stroke thrombectomy, and I will give some focus on the peri and post-operative use case here. These are my disclosures relevant to this talk, are my disclosures with Siemens and Circa and Boehringer Ingelheim. So I'd like to start with a case. So it's a very standard case. There's not much to see. NHSS 15, left M1. And here you can see the final angiography run, and I guess some of you are interventionalists. So it has been rated as a TICI 3. Here you can see the corresponding cone beam CTP, and what you can see, obviously, there's still something left, which was missed here. So there is a distal ACA occlusion, which was not noted by the operator. Just another case. So this was also an M1 thrombectomy. You know where this is going now, so take a look. Where are the residual occlusions here? And so this has been rated as a TICI 2C 2B with some parietal deficit. And let's look again at the cone beam CTP here. And you can see, yes, there is a parietal deficit, but also actually the complete temporal lobe is missing here. So there you can see in the lateral view that has been the temporal branch occlusion here. So this is just for starting, and I'd like to give you an overview about the past of cone beam CTP, how to do it, the scientific background, its value in thrombectomy, which is the largest part of that talk, the projects we are doing, and how the future can look like. So the past, I'd like to keep that very brief. Basically, here's an overview from 2019. You can see that most of the stuff which was done was 2 sweeps. So it's basically a CBV done, and mostly Siemens machines here. So how did this work? You do a mask run, then you inject IV, you wait, you do a DSA, you wait until the venous phase with DSA, then you do another run, and these are the maps you can get. So it's basically CBV. It's now an old technique, but still, as you can see here, it was one of the first peri-interventional reports of the no-reflow phenomenon we also heard about today. So this brings me already to the status quo now. And the status quo now with the RSI Cono is that you basically have a 5 seconds acquisition and then 1 second back, 10 times. You have 2 mask run. You start injecting at the very beginning here with a dual injector pump. These are the images in its raw data form. And what you get out of this are the different phases, native, and then the contrast is arriving, and of course then venous phase. Some practical aspects, because as Sebastian already said very nicely, it's important to track all the details during acquisition. So you have to keep in mind it's a 60-second acquisition, so movement is of course a problem. Inject the contrast immediately when you start the run. So the first 2 runs are still native because it needs some time for the circulation. The contrast is IV. You can blend in for dose reduction. Look out for artifacts. I mean, there can be mobile phone, earrings, and I'll show you another case what could be in the field of view. Catheter placement, of course, if you still want to do something, maybe pull it back in the CCA to not have artificial flow reduction. Use inclination of the head to reduce the beam hardening artifacts in the posterior circulation. And of course, if you don't have a double injector pump, you can use layering of the contrast and water. So it's about 3 to 5 millisievert. So use collimation, then it's 3 millisievert. Here's a case with an artifact, and this is the raw data. So the anesthesia said no, there was no mobile phone in there. But actually you can see something is there. So it's always anesthesia. So what they actually did is they tried to check the gastric tube placement with contrast. And obviously what happened is, this time for real it was anesthesia. There's the contrast, and this was causing the artifact. So I can just reiterate on Sebastian's points. always check if there's something there, otherwise you will have artifacts, and in this acquisition, this is a problem. So regarding protocols, I don't go into the detail. This is what has been published. Basically, what you can keep in mind is both work, so 40-40 contrast and then the chaser, 60-60. You don't necessarily need a pre-bolus. Both work, both have okay quality in our experience. How this then works, you have the 10 phases. So this is 1 minute acquisition time. It gets immediately processed. It gets sent post-treatment time to CERCA. So the post-treatment time is 1 minute 30 seconds, and then it gets pushed back. We have some tricks of how to reduce the transfer volume. I will cover that in the course. So, and then the total transfer time back and forth is around 20 to 30 seconds, and then you can nicely see here you have the DSAs, and next to it you can scroll in the angio all these perfusion maps. So 2 minutes in total. So the scientific background, Sebastian already covered some of it. There's not much available actually. Regarding this 10 phases, or in the beginning it was 9 phases protocol, there was the Erlangen group which did aspects grading on different maps, which showed okay correlation. We did something with a research prototype from Siemens, which, as Sebastian said, it has very good correlation for the hypoperfused volume, less so for the CBF and CBV. What we now did is actually a large comparison of 35 patients which had a CTP or MRP, and then again a cone beam CTP before the intervention. And this is a radiological rating, but also a rating of a quantitative analysis of the segmentations, and these are 13 raters, all blinded, randomized fashion, so it's a high scientific standard. And here are just some examples. So this is all pre-intervention now, ACA occlusion, cone beam ACA occlusion, even for infratentorial, so basilar occlusion, you can see here that correlates nicely, but you see already also for CBF and CBV there are, of course, some differences, but this could also be pathophysiological true differences, is hard to say. Regarding the AIF rating, you can see it's almost the same. There's no significant differences between a multi-detector and a cone beam CT. When you check the rating, so how good is the percentage of truly rating the exact occlusion, it's almost the same. So when multi-detector people read again the multi-detector versus the intermodality rating, it's almost the same. The only difference here is that in some cases there are significant differences for CBF and CBV. This has some technical reasons, but also it could be that the situation changed, because in some of these cases the cone beam CT was acquired 30 to 60 minutes after the initial multi-detector or MRI. So if you look then now, if you reread, this is the intermodality. So this is multi-detector versus flat panel. So this is the overall score. It's actually almost the same if the raters reread just the normal multi-detector CT, so it's comparable. You will have the same territory rating irrespective of what maps you look at. So I now come to the heart of this talk, which is the value of all of this in thrombectomy. And I like to stress in the beginning, my take is that it's not for pre-interventional use. You can use it and it performs quite well, as you have seen. But the really added value in comparison to other imaging techniques is during or after thrombectomy. So what are the use cases? So the first one, as I just mentioned, is direct to angio workflow. This is not the main part of that, but it can be used. And then this is one thing which works out of the box. It's currently possible. So for residual occlusion detection, for assessment of post-reperfusion hemodynamics. And there are other things. So it's, for me, it's a one-stop shop. You can get other information out of these 10 phases, which are clinically very, very important. So let's start here with the direct to angio. Again, the case with the ACA, for example. The problem I see is that the evidence for the clinical benefit of the direct to angio workflow is not that clear at the moment. So there was one RCT in France which was halted for safety reasons. So I think in general this needs further studies, but the CBCTP and this protocol with the 10 phases, this can of course supplement the workflow. As you can see here, it produces maps which are similar or almost similar to multi-detector CT. So this is, now we come, the last 3 points are really perioperative, post-operative use, where you have to think of there's no other modality at that moment available, right? This is also why I guess there's the strongest benefit of this technique. What is the problem? We know that if operators rate TICI, DSAs, and a core lab, we overestimate largely our own success. And this has been associated with several kind of locations, but also overnight thrombectomies, so all the stuff you can imagine, right? So, another case, thrombectomy, M1. This is DSA, TICI3. So if you look at again, it's a very famous location. So if you look at the maps, Tmax, OEF, CTH, and we really like these two maps here, OEF and CTH. They have relatively low noise and a nice contrast. So if you look at that, where that is actually, you nicely see that again, the temporal lobe is missing. And of course, this is a location which is missed a lot of the times actually on angiography, and it perfectly fits also the capillary phase deficit here. Actually, the occlusion was there. It's hard to see because the contrast gets washed away because the occlusion is immediately at the bifurcation, so you don't have a stagnating vessel there. Another case, so again M1, you can see there's something here, you can think of that being an artifact, but if you then have a closer look, you see that there are several occlusions in this central region, and actually the infarct grows if you compare the pre and post MRIs exactly in this area over there. Again, I mean, I'm not saying that people would miss these, right? It's very easy to see that there is a capillary phase deficit. But of course, if you compare that to an image like that, you know exactly where that is. You know exactly also the reduction in CBF you see in this occlusion. And obviously, the infarct growth is exactly in this area over there. So it's a very nice correlation of residual occlusion hypoperfusion and then the infarct developing in exactly this area. And also one point I'd like to stress is, what do you think if you communicate with your neurologist, if you say TICI to be 67 with the residual M4 occlusion frontal, or you just show the perfusion maps? Neurologists usually know how to read a perfusion imaging. It's far easier, and they can correlate it with the 24-hour neurological deficit, and they know, okay, this was actually the thrombectomy result, so it's clear that the patient still has some kind of deficit corresponding to this deficit over there. So also for communication of the disease state, I think it adds to the communication between the teams. Other case, that was admission. There was actually a thrombectomy for left M1, but then on cone beam CT, someone noted something, maybe an artifact, maybe not. It was just another occlusion occurring between the admission and the transfer to thrombectomy. So even for different territory detection, and we have several cases of that, it helps because at that time point when you like to finish, you can see if there's another occlusion in another territory. So the real estate mantra is exactly the same as the perfusion mantra. So it's all about location, location, location. So if one will show you this deficit here, is that eloquent or not? People can say, yeah, I can rate it on the DSA. Data shows that the kappa inter-rater agreement for rating eloquence on a DSA is extremely poor. You can now say, okay, this perfusion map doesn't help. Well, I mean, you can see both of these occlusions. The thing is, of course, you now have a three-dimensional data set. What we can do with three-dimensional data set, it's also clear, right? You can match it, you can put it there, you can see where this is anatomically, and exactly there, the patient had the follow-up infarct with a corresponding neurological deficit. So in cases where you'd like to go there with intraarterial thrombolytics, I mean, this is probably not a case for any mechanical maneuvers, but you can then keep in mind also what would be the eloquence of the residual hypoperfusion. And of course, you can also train that. This is work of a PhD student here. He trained on 1,500 perfusion cases for prediction of the NIHSS. So what you can do now, you can take the cone beam perfusion, you predict the deficit, and then you can make your decision more informed as before. If you don't like these kinds of NIHSS prediction, what you can also do is you simulate the structure of a CT by diffusion models. And then you can see here the cone beam CT, the multi-dissector CT, and this is the virtual cone beam CT, which you can create out of these images alone. And then you can nicely see actually that it has a very, very good anatomical structure here. And if you look at it in more detail, so the sulci, you can really anatomically say where this perfusion deficit is. And this, of course, brings you more information for your decision making. So location is possible with that. We also talked about this morning about other, more subtle hemodynamic alterations after the reperfusion or recanalization. So, what is well known? M1, thrombectomy, severe hypoperfusion, OEF reduction, and on follow-up, exactly the same. It's not an artifact of a CBCT acquisition, it's real-time pathophysiological monitoring of a hemodynamic state. You can now directly see in the angio, and also for the SWI, you can see less susceptibility artifacts corresponding, of course, to this hemodynamic state. Another case here, you can see Tmax. It's actually accelerated. So this is what you expect, right, in a hypoperfusion. And you see the CBF, you see the OEF, and then you make the 24-hour MRI perfusion, exactly the same, SWI, vein susceptibility reduction. So everything fits, but you already had this information 24 hours before, when the patient was still in the angio. So, like I said before, it's a pathophysiological imaging of post-stroke hemodynamic right in the moment, 5 minutes after you've done your thrombectomy. Another case, we have talked about the no-reflow phenomenon this morning. So you already see there is a large extravasation of contrast, but no real, maybe a small one reduction here in, or delay, suggesting residual occlusion. But the main thing is that CBF and CBV is severely reduced. All vessels are open. And you can see here, this is the follow-up. You can now ask yourself, okay, is this no reflow, or is actually edema causing no reflow? This is something nobody has figured out. I'm also very skeptical of the relevance of this phenomenon, if it's just an epiphenomenon or not, but you can image it, that's for sure. And this has been done several times, and it's not the same as a residual occlusion deficit, right? This has been overlooked in 90% of the cases, that a lot of patients have residual occlusions, and we are so bad at recognizing those on DSA that 80% of the no-reflow people describe are just residual occlusions. And here's it again, and I want to stress it again, it's not the same. So a very distal territorial hypoperfusion is not the same as a no-reflow phenomenon. And you cannot adequately do that on DSA, but you can do that on cone beam CTP. But we also have even more subtle hemodynamic changes. So this is a very recent case, M1 stenosis, symptomatic dual antiplatelet. There are collaterals over here already, and you can nicely see collaterals from the ACA, a changed internal border zone, then collaterals again frontal, and then some antegrade flow here in the middle MCA territory. I put in a cardiac stent there, and then we acquired a cone beam CT, and what you can see now, again, is you have hypoperfusion in the middle, initially antegrade MCA territory here. You have reduced oxygen extraction over here, but at the border zones where there was a lot of collaterals, they are still pressing because it was a chronic occlusion. So exactly in those areas where you had collaterals, you still see a delay because the competing collaterals are still active. And this is something you can also see after thrombectomy. So you don't have to confuse this with residual occlusions, and we are working on how to distinguish these two. And then you can also make some reconstructions out of the perfusion imaging. Which brings me to the last point, which is you can do perfusion, but you can also make pictures like that. This is out of the 10 phases acquisition. These are images, and I think they are a lot better than the usual CTAs I see. So there's a lot of detail. And for example, this is another case, a recent case. This is a post-thrombectomy run again. So it was a P1, P2 occlusion. And this is actually the arterial phase of this cone beam CTP acquisition. There's a lot of detail, and what you can see is you can even reconstruct the arterial phase there, and what you can see is there is, of course, a stenosis. I mean, yes, you can see it on DSA, but it's way harder. A lot of people would have missed that. It's hard to miss on these kinds of reconstructions. Another thing, we always see a lot of subarachnoid hemorrhage, or let's say hyperattenuations after distal thrombectomy. Sometimes we do temporal coiling, and then we want to know, is this still bleeding? Of course, in this case, there was a 7.5 second zoomed in DSA. It was unclear, but in perfusion, you can see in the late phases, there is still contrast extravasation. So even there, the 3D helps you to detect these kinds of complication. And just another case. So this is the second thrombectomy I did in this patient. I acquired a 4D DSA to see that what actually caused this reocclusion. But if you go back to the first acquisition of perfusion, you could also see these irregularities here. And probably I should have known this and I should have looked at this. Then I would have done another 10 or 15 minutes delayed DSA run and probably would have detected this reocclusion way earlier, or that there is a problem and thrombus formation. So also there, it helps. This brings me to projects. There's still some minutes left. So this is a prospective study we did on cone beam CTP after thrombectomy. And this was a 2-center study, so in Switzerland, and now we're almost done. So this is 240 patients with the cone beam CTP acquired. And we're happy to present that we are going one step further to have that more in more centers with more heterogeneous workflow, so without GA, and also transferring that to other diseases, of course. So it's a highly collaborative approach. People can put in projects and work on this topic. It's a clinical validation and also technical development study. And we are looking forward to launching this in 2026. So the future. You can now ask yourself, okay, it's nice to see, but what is actually the clinical relevance of all of that? So for me, the stroke imaging landscape is changing. We started with very advanced imaging before. Now nobody cares about advanced imaging for an M1 occlusion. We do it all. Basically, it has value, of course, for distal vessel occlusion detection, stuff like that. But I think the landscape is changing. So we are now in more and more centers doing direct to the angio workflows, maybe doing native cone beam CTs for complication detection. But I think the future will be that we do more advanced imaging actually after the intervention, when the risk-benefit is less clear than before, because now you have the problems of M3 occlusions, M4 occlusions, maybe it's still bleeding, maybe you want to give intra-arterial thrombolytics. So this is, I think, the next generation advanced imaging. It's not before, it's within the angio, it's directly postoperative to guide your decisions. We have some negative trials, although there are newer ones which are positive, but mostly negative for distal thrombectomy. But at the same time, there's a lot of intra-arterial thrombolytics trials, at least pooled, showing benefit. So also for these, the question is, for whom do we need these kinds of treatments? So this is a case. If you would have known that this perfusion deficit would have caused this infarct, I think, yes, it's a perfect candidate for intra-arterial thrombolytics, right? This patient here is with some collateral flow, not so much because it's not inclusion, it's collateral flow. Hyperperfusion with the risk of bleeding, no, this is not a patient for intra-arterial thrombolytics. Again here, peripheral hyperperfusion, no. This is the opposite of no-reflow. You don't want to treat this patient. So the value is quantitative perfusion assessment, sensitive detection of residual perfusions, treatment decisions. You can evaluate the eloquence of the tissue. You can do 3D vessel reconstructions, bleeding detection, and risk stratification. So all of this in a really one-stop shop. So my new definition of one-stop shop is actually you do it afterwards and you get a lot of multi-modality data. So I like to close with that. We can only treat what we see. And for that, we need good imaging at the right time point. And I think CBCTP is for that the way to go. Thank you to these collaborations with these two companies. And you can now directly see it in the angio. And with that, thanks to all the collaborations, to the team. And I'd like to invite you to this course here for a general overview of advanced imaging. And thank you for your attention.
Thank you for this impressive overview and view into the future. We have time for a quick question from the audience. Otherwise, I would like to ask you a question I asked before, and that is anesthesia. How does this play into all of this?
Yeah, well, it's better if the patient is sleeping, right? I mean, but I think there are good ways of fixating the head and stuff like that. It all points down. It's a team effort, like Sebastian said. So it's like you have to talk with anesthesia. You have to talk with the technicians that everything is prepared. But if you do that, and if you train the team, you can boil it down to so these images are done 2 minutes after the final thrombectomy maneuver. So it's possible, but of course it needs some training. And also, of course, when you start with a new process, everyone is not happy because it needs more work. But once this is initiated, I think there is some value to it.
Thank you so much for this. Was there a quick question? Yeah.
Yes, super. For the post-procedure convened CT, how does the contrast, let's say long intervention, okay? How do you distinguish the hypoperfusion from an artifact from the intra-arterial contrast?
Yeah, I mean, this has been unsolved because this is also true for people doing normal CTPs after the intervention. There's the Barcelona data set. My impression is, of course, because this is not a linear function of X-ray observation, so you have some problems that already there's a lot of iodine because of the blood-brain barrier breakdown. I think nobody knows. For the residual vessel occlusion detection, I don't think it's an issue. For CBF and CBV, defining no reflow, yes, this is a big issue, and probably partially related to the fact that in CTP, directly after thrombectomy, you see CBF, CBV reductions, which are probably not real to some extent. But it's something to be solved and validated. Totally agree.
Thank you so much. Let's give an additional round of applause.